Discover the 2 key features that help you decode chronic kidney changes from long-standing hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 54-year-old woman with hypertension for 18 years and stage 3 chronic kidney disease is evaluated for slowly declining kidney function. Her history includes epilepsy, stress urinary incontinence, and a repaired inguinal hernia. She currently smokes 1/2 pack per day and recently returned from Asia. Nickel contact causes localized skin irritation. Her father had hypertension but no known kidney failure. Her medications are lisinopril 40 mg daily, amlodipine 10 mg daily, and levetiracetam 750 mg twice daily. She reports good adherence. Her pulse is 82 per minute, temperature is 37.1 degrees Celsius, respiratory rate is 16 per minute, blood pressure is 120 over 64 millimeters of mercury, and oxygen saturation is 97% on room air. Examination shows retinal arteriovenous nicking and a mild left ventricular heave, but no edema, rash, joint swelling, or abdominal bruit. Estimated glomerular filtration rate is 38 milliliters per minute per 1.73 square meters, normal at least 60 milliliters per minute per 1.73 square meters. Potassium is 4.2 milliequivalents per liter, normal 3.5 to 5.0 milliequivalents per liter. Urine albumin to creatinine ratio is 180 milligrams per gram, normal, less than 30 milligrams per gram. Hemoglobin A1C is 5.4%, normal, 4.0% to 5.6%. And urinalysis shows 1 red blood cell per high power field, normal 0 to 2 per high power field. Chest radiography shows mild cardiomegaly without pulmonary edema. A dual-energy X-ray absorptiometry scan obtained during long-term antiseizure treatment shows osteopenia. Which renal biopsy pattern is most consistent with her chronic kidney disease? Option A. Hyaline thickening of small renal arteries and afferent arterioles with luminal narrowing, global glomerular scarring, interstitial fibrosis, and tubular atrophy. Option B. Nodular mesangial expansion with Kimmel-Steele-Wilson lesions, thickened glomerular basement membranes, and hyaline change in afferent and efferent arterioles. Option C. Concentric hyperplastic arteriolar thickening with onion skin narrowing, fibrinoid necrosis, glomerular ischemia, and acute thrombotic microangiopathic injury. Option D. Granular immune complex deposits along glomerular capillary loops with endocapillary proliferation, subepithelial deposits, and diffuse podocyte foot process effacement. The correct answer is option A, hyaline thickening of small renal arteries and afferent arterioles with luminal narrowing, global glomerular scarring, interstitial fibrosis, and tubular atrophy. The expected biopsy pattern is chronic hypertensive arterionephrosclerosis, traditionally called benign nephrosclerosis when contrasted with accelerated or malignant vascular injury. 18 years of hypertension, retinal arteriovenous nicking, a left ventricular heave, chronic moderate albuminuria, bland urine sediment, and slowly declining kidney function support chronic pressure-related vascular and ischemic injury. Hyaline deposition in small renal arteries and afferent arterioles narrows their lumens, producing chronic glomerular ischemia, global glomerulosclerosis, interstitial fibrosis, and tubular atrophy. Onion skin hyperplastic arteriolosclerosis, fibrinoid necrosis, and acute thrombotic microangiopathy indicate accelerated or malignant hypertension rather than a stable blood pressure of 120 over 64 millimeters of mercury with slowly progressive disease. Kimmel-Steele-Wilson nodules and hyaline change in both afferent and efferent arterioles indicate diabetic nephropathy, but the hemoglobin A1C is 5.4% and there is no diabetes history. Immune complex deposits, endocapillary proliferation, subepithelial deposits, and diffuse foot process effacement imply an immune-mediated glomerulopathy, which would more often produce active urine sediment, greater proteinuria, or systemic inflammatory findings. In summary, chronic vascular injury from long-standing hypertension produces hyaline arteriolosclerosis and secondary nephron scarring. The bland sediment and absence of diabetes or inflammatory features narrow the pathologic differential. Current pathology reports often use arterionephrosclerosis rather than relying on the older benign nephrosclerosis label. Primary teaching point: chronic hypertensive kidney injury is predominantly vascular and ischemic. Secondary teaching point: biopsy interpretation must integrate tempo, urine sediment, metabolic history, and evidence of systemic target organ damage. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.
Endless Medical AI is the medical chat where 3 AIs cross-check every answer. EndlessMedical.AI